So we are going to change gears, and I am going to introduce myself. I am Felice. I'm the new IBD director at University of Cincinnati. I recently came from New Orleans, and so I'm new to Ohio and happy to be here. I am going to talk through how we monitor IBD disease and how does that look like for patients in clinic. And we're going to talk about a little bit of the STRIDE 2 recommendations, which was put forth by an IBD expert panel that came up with consensus statements of kind of sort of how do we need to monitor our patients over time in the IBD clinic. So we know that clinical symptoms does not give us an indication of what is exactly going on in the patient's gut. So what I mean is patients may have, symptoms of diarrhea, et cetera, but that does not usually tell us how much inflammation is in the gut, or are there any complications and how much damage is in the gut. And this is a great picture here that can show you that patients' clinical symptoms may go up and down over time and may look like a roller coaster. But what we don't realize is that actually bowel damage is accumulating and strictures are forming and abscesses are forming without the patient knowing clinically that that's happening. So what we're trying to do is we're trying to ask patients along the way, what are your symptoms? But at the same time, monitor some objective measures of disease activity as well as severity to make sure that we actually not just have you in clinical remission, but also prevent cumulative damage in your bowel. And so that's when we talk about this concept of treat to target, right? We're picking a target that we're asking your treatment to make better. I always tell my patients, when we start off with a treatment, I know your colon has this many ulcers, and this is your disease activity today. My job is in 6 to 8 months, I want these ulcers to be gone. Along the way, I want your symptoms to get better, and there's going to be ways that we're going to monitor your disease getting better. And so it's basically combining clinical symptoms with objective measures, checking your stool samples for fecal calprotectin, checking your blood for CRP, repeating your scope in about 6 to 8 months to make sure that the ulcers that we saw at baseline actually improve over time. And then importantly, along the way, not just focusing on your symptoms, but also your quality of life, getting you back to the things that you love to do, back in school, back going on that trip that you're planning to the Bahamas, all of those things, kind of following you along, making sure that you're on track. So this led to the STRIDE criteria and putting forth for us kind of sort of in clinic, what do we need to monitor over time? And we think of them in short-term targets, intermediate targets, and long-term targets. But you can kind of sort of see here to the left side, you start off with having activity, right? And so your physician scopes you, they understand how much ulcerations are going on in your bowel. They may check a baseline fecal calprotectin that gives us a number of inflammation. We may get a blood marker called a CRP with a level of inflammation. And then we start on therapy. And then we want to monitor you along the way. We have some immediate targets, right? Immediately I want to know when I start you on a medication, what gets better. I want to hear that the patient has a clinical improvement of symptoms. It may not be normal, but initially short-term targets needs to be symptomatic response. Then kind of sort of in the intermediate targets with time, I want to see that that CRP number comes down, that fecal calprotectin normalizes, and even for kiddos, that their growth, that there's restoration of growth, right? We know that in our IBD population, in our children population, that we monitor their growth over time. And then ultimately, about the long-term targets, I want to scope you, I want to see about 6 to 8 months later that there's endoscopic healing, that all of those ulcers are either gone or significantly improved from baseline. And this is how we know that our drug is working. Looking at it in a different way, again, this is just a diagram to let you know kind of how we think about how we're going to monitor you over time. You may have active disease. We start off again by checking all those things. At 3 months, we may repeat that biomarker, make sure that after you start your induction therapy for whatever therapy that you're on, that things are getting better. I'm doing a symptom check with you in clinic, asking you what is your number of bowel movements, is your abdominal pain better? and then scoping you. And if we have not reached our target, meaning that our CRP is not normalized, the fecal calprotectin is not better, or your endoscopy is not better, that we then make changes to your regimen, right? And we go back to the drawing board and we restart and we change your drug or we optimize your therapy to get you back on target. And so treat to target. Your targets is what you need to talk to your physician about when you're in clinic. What are we targeting? What do you want my level to be? When are we repeat that scope, right? Those are the things that we discuss in clinic. So I'm going to run quickly through different targets for different diseases, and I'm going to start off with Crohn's disease. We know that Crohn's disease is a transmural inflammation, right? So that means that the inflammation goes through the bowel wall, and so we can see thickening on imaging that is different than what we see in ulcerative colitis. So in Crohn's disease, we sometimes will look at imaging and we talk about that transmural healing, and that's just a term for saying that we're kind of looking and seeing if that inflammation is getting better in the thickness of that bowel wall. So we start off with clinical response, and then normalization of those biomarkers, endoscopic response, obviously talking about quality of life, transmural healing, and then I'll talk a little bit about histologic healing, and we'll kind of target all of these individually. So remember, immediately after starting therapy, that immediate target is how much is better. I want to see that my patient's symptoms, 50% of it gets better right after induction. So I usually will bring a patient back after induction therapy and have a check-in either with myself or my nurse practitioner to say, hey, are you feeling that this drug is working? I'm expecting 50% of your baseline symptoms to be better. And remember that our baseline symptoms are all different, right? You may have abdominal pain, you may not have any symptoms. Sometimes I think those patients are the trickiest. They don't have a lot of symptoms. They may have just been picked up with anemia or some other marker. But I want to see that clinical symptoms are better of abdominal pain and bowel habits. And then later on, I actually want to see that those symptoms completely resolve. But I do want to make a point here, and this is something I tell my patients in clinic. Many times I think as patients, we want to go back to 10 years ago before I got diagnosed with Crohn's disease, or 10 years ago before I got diagnosed with ulcerative colitis. I want my bowel movements to look like that. And I think the reality is, after a diagnosis of IBD, I always talk to my patients, you may have a new normal, right? You may not go back to that one solid formed bowel movement that you had 10 years ago, right? But you now may have formed stool and it may be 2 to 3 times per day, and it's still good. But again, what are we doing as providers? We're matching that with you have a normal looking colon, and we know that the 2 to 3 bowel movements that may not look like the one in the past is good because your colon is healthy. So that new normal is something that I talk to my patients about, because we always tend to think I need to go back 10 years ago before my diagnosis and that is perfection. It's not always the case. Again, in children, we want to see that there's restoration of normal growth, and that's a new target that we have put in the STRIDE criteria to monitor over time. And our pediatrics folks check those growth curves during all of their visits. So when we talk about biomarkers, we talk about kind of having this non-invasive way of monitoring inflammation over time. So one is to check your serum for a CRP. Some physicians also do an ESR, so sometimes you will see in your blood work that you may have a CRP and an ESR that your physician is monitoring over time. The key is to know what biomarker is high when you have active disease. So the best time to get that biomarker is during your scope, right? When you have a scope and there's activity during that scope, it's good to check a biomarker at that time, because it may indicate that your CRP is elevated, or it may indicate that your fecal calprotectin is elevated. Your fecal calprotectin is a stool sample, and that gives us a number. It's unique to you. The number itself does not necessarily mean anything. It's just to know that it's elevated and that it accounts for the disease activity that's in your gut. And that's something that we follow over time. So let's say I'm scoping a patient today. They have ileal inflammation. Their CRP is elevated at 12 and their fecal calprotectin is 300. After induction therapy, when I bring that patient back, I expect that fecal calprotectin from 300 now to have decreased to at least 50% is kind of what I'm aiming for. So coming down to like 150, I now know that this patient is responding to their medical therapy. So we're using CRP and fecal calprotectin as a non-invasive way to monitor over time that patients are improving. And it's also a way for us not to have to scope you all the time. I'm sure you guys like that, right? So we don't have to constantly do scopes and scopes and scopes. We have this non-invasive way of monitoring disease over time. We do, however, want to make sure that the mucosa is normalizing. So it is important in that first year, and ideally around 6 months, and it's depending on how you're doing, to go back and get that colonoscopy again. And the reason is we want to make sure that the inflammation that we saw from the beginning has now improved or is completely gone. And so repeat endoscopy, unfortunately, a lot of times has to be done during that first year after starting a new therapy. What about when your physician takes biopsies? Well, we don't follow histologic healing as a target yet, but sometimes your physician will do an endoscopy and will take biopsies, and we will look under the microscope to see if that inflammation has improved. We know that when patients have histologic healing, when the biopsies even show that there's no inflammation, we know that those patients have a better outcome. But it's not a target that we follow. So for example, if I don't see any ulcers in a patient's small bowel, but I'm taking biopsies in the small bowel, and there's a little bit of inflammation on those biopsies, it does not mean that I'm going to change your therapy. If there's room to maybe improve your drug that you're on, maybe your level is low, we may make those adjustments, but it is not a formal target that we target. And again, in Crohn's disease, a lot of times we do use, whether it's ultrasound or a CT scan or an MRI scan, to monitor, sometimes because your inflammation is a part of your bowel that we can't reach with a scope. Some people have mid-small bowel disease, and so we don't get there with our scope, and over time we're monitoring that that inflammation is getting better. It's also a great way for us to pick up any of those complications, right? A stricture, a fistula, or an abscess, and that's when we use cross-sectional imaging. Quality of life is extremely important, and I find a lot of times with my young patients, we were talking last night over dinner about young patients transitioning from pediatric to adult. I find a lot of times with my young patients kind of also setting life goals and understanding how functional they are today, and what do we expect things to get better over time, right? We know that this disease is debilitating, and I want to see that I'm getting you back to the things that you love to do, right? Many times I set goals with my patients in clinic, and I ask them, what do you want to be when you grow up? What do you want? What's the next trip you want to take? What is the next thing that you want to achieve or do in your life? And along the way, as I'm working and getting them into remission, we check on those things, right? Because I'm trying to get patients back quality of life and preventing disability, and that is extremely important. As we treat the disease, we also treat the quality of life. And this is where our psychiatric colleagues and our support staff is so important to help us take care of the patient as a whole and doing these check-ins to make sure that patients are getting better. We're always following multiple targets, so it's not just one thing. Your physician is not just going to monitor your fecal calprotectin. They're not just going to monitor your CRP. We're thinking about all of these different ways to reach that target, right? So we know that combining these targets are better than just monitoring one thing over time. So let's switch gears a little bit to ulcerative colitis. Things are fairly similar. In ulcerative colitis, we don't look at transmural healing because ulcerative colitis is a more superficial type of inflammation. And we think a little bit more about histologic healing when we talk about ulcerative colitis. So let's go through that quickly as well. So an immediate clinical response that we want to see is in rectal bleeding and in stool frequency. I pay attention to a lot of times ulcerative colitis patients telling me if their urgency is getting better, that running to the bathroom, not knowing what's going to come out, right? Running constantly to the bathroom, not knowing, that urgency needs to get better, the rectal bleeding needs to get better, and then over time, that needs to resolve completely, and that's when I know that we're on the right path with their treatment. Again, for children, we monitor their growth over time. And then fecal calprotectin and CRP are again monitored in ulcerative colitis. I would say fecal calprotectin is a great marker of colonic inflammation, so a lot of us do like to monitor fecal calprotectins. And I will share with you, it's sometimes difficult to bring that stool sample back to clinic, right? And so what I've done in my clinic, and what you may suggest to your physician, is give me a couple of those stool vials to take home. So every time a patient comes to my clinic, I give them a kit, a fecal calprotectin kit, and it's got a lot of vials in there so that they can go store it in their closet at home. So if they're calling me and saying, hey, I'm having worsening bowel movements, not sure if it's eating out of the taco truck last week or the trip I took or, late night last night, I'm not sure what's going on, then I will say, hey, I'm putting an order in for fecal calprotectin, collect your stool, drop it off, I'll see you next week. By next week I'm seeing them, I have that fecal calprotectin back, right? So when you're in my clinic, now we can have a conversation. Hey, your fecal calprotectin when you had active disease, when I scoped you last time, was 300. Right now it's 20. It's probably the taco truck, right? Or something like that. So fecal calprotectins, we need to create ways for it to be easier because it is such an amazing tool. So ask your physician, hey, can I get an extra vial? Keep it in my closet and then take it in. And then I always tell patients if they don't have a container, just doing it in a sterile container like a Ziploc or things like that. And when they get into the clinic, we can transfer it into the right container. Is completely acceptable. So there's ways of sort of getting those fecal cals that you don't have to drive all the way to the physician's office, pick up the right vial, now go all the way home, now collect your sample, and then go all the way back. I mean, who wants to do that? I practice downtown. Nobody is coming downtown. And there's a river. Nobody crosses the river. It was the same in New Orleans. There was a river too, and they don't cross the river. So, all right. Endoscopic healing, again, doing that colonoscopy, or sometimes for ulcerative colitis, we have the flexibility of doing a flexible sigmoidoscopy, which is the shorter scope. Doing that scope, making sure that the inflammation that we saw at the beginning is completely healed. That is extremely important. That's 6 to 8 months after therapy. We are monitoring a little bit of histologic healing in some of our ulcerative colitis patients. We are taking biopsies and seeing if we can get a patient there. I think it's extremely important in some of our patients who may have PSC, which is a type of liver disease that increases your risk for colon cancer. And so maybe that's a group of patients, or maybe somebody who's had a family of colon cancer. We monitor maybe them a little bit more closely, looking to make sure that some of those biopsies are normalizing. I'm certainly not changing therapy dramatically if the biopsies still show minimal inflammation, but it is very good to see when there's no inflammation on those biopsies. And we do know that there's better outcomes. Transmural healing, again, that looking at the thickening of the bowel, is not something that we do in ulcerative colitis. That's more of a Crohn's disease thing that we monitor with CT and MRIs. We don't really do that in ulcerative colitis. And again, talking about that quality of life, right? Making sure that along the way that those things return to normal. And just to sort of summarize again, your physician are constantly thinking about how am I getting you to that next target. That first year after you start a new therapy is when you're going to see your doctor much more in clinic, doing a lot more fecal calprotectins, getting a lot more blood work done, getting those scopes done. And then once you're in remission, you may only come back every 6 months or so, or every 3 to 6 months with a repeat fecal calprotectin. And that's the nice way. Now I've scoped you and things are normal. Now I'm just keeping an eye on you non-invasively, right? By you submitting a fecal calprotectin over time, and we know at that point that we're still reaching our target. I'm going to leave this up here for just a quick second. I just want to make a point, and this will be in the slides that are available to you, that remember that different medications will get you to that target, some faster than others. And Ben was talking about, some therapies have faster onset, so some therapies work quicker than others. And so here are just some rough guidance that the STRIDE group put together to just in the background know that some medications will take time to get you to that endoscopic healing, normalization of fecal calprotectin, because they're all different in terms of onset of action. And so the take-home point today is just that this treat-to-target strategy really aims at getting your clinical symptoms completely better. But remember, you may have a new normal, right? And your clinical symptoms needs to match what's going on in your colon. So we need to take a look and make sure that you've achieved mucosal healing. We need to look and make sure that you have normalization of that fecal calprotectin or that CRP, that we have restoration of growth in children, and that we get you back to those things that you love to do in life. And with that, I'll finish. Thank you very much.